any confusion between the two meetings. So this is our quarterly primary care council. Sorry, still am having issues with my window. Okay. All right. Are the slides changing? Okay, great. Thanks, guys. Like always a challenge with technology. So yeah, thank you all for coming today. As we do with every primary care council, we like to do a land acknowledgement. I can do mine like I did at the last quarterly meeting, unless someone else would like to. I'm gonna guess people would like me to do it. So I'll go ahead and just get started with mine. But again, as I said last time, I'm happy if anyone else wants to share their own land acknowledgement. I think it's always really interesting to hear other people's because they can vary quite a bit. So I'll just read mine. This is the one I've come up with over the years. So I'm honored to live, grow in relationships, and create on the unceded sovereign lands of the original peoples, what is now called New Mexico. With a full heart and clear intention, I commit to ongoing learning and to the hard work of dismantling settler colonial ways of being and doing. My foundation, whether in practice, justice, work, or growth, is grounded in historical truth, reconciliation, stewardship, and restoration. I remain committed to honoring these truths and to walking a path of equity with action and not just words. So that's my. Want to have something to share? All right. So again, just to ground our work here at the Primary Care Council, this is the mission, vision, and goals of the Healthcare Authority. And so obviously all of the Primary Care Council goals and really vision align very much with these. And so again, here are the Primary Care Council mission and vision to revolutionize primary care.
Okay, it's on yours too. So go ahead and jump on yours, and then I'll get you introduced. Then we can rock.
Dan, I'm going to go ahead and mute you about that. So yeah, interprofessional sustainable teams delivering high quality, accessible, equitable healthcare across New Mexico through partnerships with patients, families, and communities. Okay, and then again, this is a lovely slide Elisa had put together before I started, so I can't take credit for it, but really outlines the various duties of the Primary Care Council as it's outlined in the House Bill 67. So again, to just ground us in what the work of this council is focused on. Here is today's agenda. So if you had seen the one I posted, we just have one slight change. So Elisa, because she has some other meetings going on, she's going to go ahead and kick us off with our first agenda item. And then Jessica will go ahead. So we just switched those two. So again, just the norms for today's meeting, same as usual. This is really a long meeting, so obviously take the breaks that you need. If you have anything specific for future topics, questions, anything like that, feel free to send me a chat in Teams, or you can email me as well. Because we are all virtual, if you guys can raise your hands when you have questions to ask, that also would be very helpful. And I'll pass it to you, Val.
Thank you. Good morning. It's good to see everyone. So yeah, just to sort of reiterate what Tristan said, I think it's always really important that we remember some of those key concepts in the PCC mission statement. So that's the interprofessional teams, high quality care, accessibility, and equitable care. Those I think are sort of the grounding principles of this committee. So good to keep in mind as we go through the agenda today. And there's some really exciting things, I think, on the agenda today. Looking forward to hearing from Elisa about what's happened and is happening on the federal level and also in the recent New Mexico special session. I was very excited to see the additional funding for the Rural Healthcare Delivery Fund, which I'm sure we'll hear more about, but really appreciate everyone's advocacy and hard work making that happen. You probably also saw that we recently submitted the letter to the RFI for the Rural Health Transformation Project. And again, I know that Elisa has much better information on that, but I think that's going to be a really, hopefully, good infusion of funds to help support and mitigate some of the coming federal changes, particularly for our rural areas. And I appreciate the opportunity to advocate for and include primary care in those plans. I think that, especially when funding is limited and some services might be at risk, that we really prioritize primary care as the backbone of our healthcare system. I also wanted, if we can, to sort of keep in mind as we hear from each other and our partners today, Dr. Andazola is going to do a report out from the Workforce Committee with some fairly specific sort of recommendations and next steps, and would really love to see in future meetings report out from other committees, but also to think about, as we prepare for the 2026 legislative session, are there, maybe 1 to 3 or 4 discrete asks, discrete priorities from the work groups that the PCC could pull together. The Workforce Committee is going to be working on a white paper that sort of gives some more detail and evidence for some of the recommendations. And I'd love to see us work towards something that represents the full PCC and has those sort of specific recommendations for legislature. So I will pause there and I believe turn it over to Elisa.
Thanks, Val. Good morning, everyone. It's so nice to see all your faces and so glad you're here this morning with us. I see John waving. Go ahead and go to the next slide. I can't stay the whole meeting today, so before I go, I'll pop my email in the chat, and if you have any questions on anything I covered today, feel free to reach out to me. I'm happy to connect with you all and work with Tristan to get you answers if you have extra questions after this, since I'll have to go. So we had a very successful special session. Governor Grisham really helped us get the session going and had some great ideas about how to expand and support the state through this period of time that's going to be very challenging with HR 1 changes coming. So we do have $162 million coming in emergency funds to protect those food and health programs due to federal cuts to SNAP and other programs. We also received $66 million for SNAP, food banks, staffing, et cetera. And then we did get, Val, thanks for the shout out on Rural Healthcare Delivery Fund, an additional $50 million. We were also able to change the statute for Rural Healthcare Delivery Fund to expand, not just to expansion and new services, but to sustainability and stabilization. So we are currently working on promulgating rules for the new application that will need to happen for that 50 million, and really adding the option for folks to apply for those sustainability dollars across our rural healthcare system. So those are the highlights from the legislative session. So let's go to the next slide. Okay. NMDOH has also been doing some work, and I think Alana, if you're on the call, you might have some information to share too. But they've worked hard to ensure access. Yeah, go ahead, please.
talk about this. It's a very tangled web. So it's not quite sure how much detail folks want, but you know that for vaccinations in general, the way they're usually determined, there's both FDA approval, and then there's also the ACIP, which is the Advisory Council on Immunization Practices, which is a federal council. And we have learned how tangled our state law and state policies are with ACIP recommendations. So the COVID-19 vaccine, it was not FDA approved like universally under the age of 65. It was more shared decision making. So it was kind of an FDA approval piece, and then there was an ACIP piece where similarly it was kind of shared decision making rather than universal recommendations. And then the other problem was that with what was happening with the CDC director, the ACIP recommendations needed to be signed off, and weren't signed off during this at the time of the special session. So kind of the end of the story, there was many chapters between what I just told you and the end, is that we have it pretty ironed out from all sides as far as the COVID-19 vaccine. So there is a mechanism to purchase the vaccines now for clinics, and everybody of all ages should be able to get their COVID-19 vaccines. We both gave guidance to pharmacies that they could give the vaccine, and we also there is a standing order from the Department of Health so that any insurance companies, including Medicaid, that need a prescriber, if it's not ACIP recommended, it's now covered because there is a prescriber. It's Department of Health. So we came from a lot of different angles, and it should hopefully be a smooth COVID-19 season. I would say that that's just chapter one. I anticipate we'll be having similar conversations about other vaccines in the future. But I'm happy to answer any questions if people want to know more.
Thanks, Alana. I knew you knew more of the background than I did on this one, so I appreciate it. All right, let's go to the next slide.
Quite a few weeks. That was a painful one to try to figure out.
Thank you, Alana, for making that happen. It's really huge for New Mexico. So I'm sure it was a lot of work, but very important.
All right. So, we're also tracking the federal government shutdown that does or can affect what's happening here at the HCA, but please keep in mind the HCA remains open. So we are not closed. Nothing is changed as of today. Right now, no immediate impacts. And if there are any impacts coming or that we become aware of, we will be sharing those out as soon as we can. But as of now, Medicaid's open, SNAP's open, everything's operating business as usual. So and our top priority is ensuring that everyone gets that continuity of care, access to care, et cetera. So really no change now, but just know we are tracking. All right. Next slide. I think that was the last slide for me.
Yeah, I think that's it,
All right.
Elisa. If
Well,
anyone has any
thank you.
questions, yeah.
Val, you have your hand up?
Sorry, just a quick question on government shutdown stuff. Do we have a sense if there have been any VA or IHS impacts that would significantly affect health here? I haven't seen anything locally. I'm just curious.
I'm not aware of any personally. That doesn't mean there aren't any. Matt, you have your hand up. Do you have any insight into that? Oh, okay. He went away. Yeah, I can get back to you, Val, and see. But since we don't manage those programs, it's harder to know.
And I don't have any insights. Sorry, guys, I pressed the wrong button there.
Oh,
But
no worries.
I can tell you that our National Advisory Committee on Rural Health and Human Services is no longer exists after 46 years. So I don't have a direct line to ask the question to anymore officially. That's the bad news. The good news is that the the 98th convening, because we convene twice a year, was in New Mexico, in Las Vegas, New Mexico, and those federal policy briefs are still up and online. And as far as I know, they're not gonna, take the website down. So, but yeah, so that's my input on that. But Val, I still have unofficial lines. Tom Morris, who ran the committee for so long, he'll actually be presenting with me on Tuesday at the NASEM conference. So I'll see if I can get an answer for you. But I had a question, was really more my reason for putting my hand up.
Sure.
And I know you got to get off, Lisa, but with Alana on, do we have any, and it relates to my presentation on Tuesday, do we have any update on Medicaid billing for CHWs?
Yeah, I mean, I think that should be mostly ready to roll as far as the CHW repeal and replace letter of direction. So if there's issues, we definitely want to hear about it. But we did issue that maybe a month ago. So some of the main problems that we had been hearing was that the attaching of a standing order to a claim was causing all kinds of problems, that there were places that there was a prescriber and the prescriber could prescribe it. Just to kind of like back up, the reason we need a prescriber has to do with our state plan language and the federal requirements. It's not really like about their license or anything, but that's just like how we draw down the federal money. So we did issue a new letter of direction that says, you can get a prescriber from anybody. It can be somebody in the clinic, etc., and that you do not need to attach if a provider does use the standing order, a CHW, they do not need to attach that to the claim anymore. It's just like hypothetically it could be audited. And I can drop that letter of direction in the chat. Just like what we're seeing is like there's definitely been like a nice steady uptick in enrolled CHWs. We're still, I think it's a little too early to know if it's fixed the claims problem. But if you're still having trouble, I would definitely like to know, because we're hoping this is the solution.
Well, yeah, and I think what would be helpful is, so, back to the committee, when we visited Oregon, they reported, their healthcare authority reported that, they had after their first year, they had $2,000 worth of billable claims for the whole state of Oregon. And so anyway, at some point, I'm sure we'll be able to get some sort of data that shows not just that we have more CHW certified, but some dollars are rolling out from Medicaid or from healthcare authority to pay claims. And so, yeah, I guess that, now after 30 days later is probably a little too early to ask, Alana, but that would be some comparison. I would just say that Oregon set the bar really low, $2,000 for an entire state. So hopefully we could do better than that in the first year.
When I come back, I can kind of do like a quarter over quarter providers enrolled and claims paid. Okay.
Thank you.
I can try to have that be like a standing item at this meeting.
That'll be awesome. Thank you.
Thanks.
Okay, thanks everybody. I will turn it to Jessica. Everyone have a good day. Thanks for all the work that you do. Appreciate you all.
Thanks, Elisa.
Yeah, hi everyone. I'm Jessica Osenberg. I'm Senior Director of Community Health and Engagement at Roadrunner Food Bank. We're going to talk a little bit about the brand new statewide Food is Medicine Collaborative. And just a show of hands, how many have heard a little bit about Food is Medicine through Turquoise Care and that it's underway? We're able to get medically tailored meals and groceries out. Wonderful. All right. So I see some hands there. So this is just a save the date that the Food is Medicine Collaborative is going to kick off this month. And it is hosted by Roadrunner Food Bank and partners. And we have two different options. It's the same meeting. We're just offering a couple of different times to accommodate schedules. If you want to go to the next slide. So just a little bit of the background to the Food is Medicine Collaborative. As many of you are aware, the Food is Medicine program to Medicaid went live on July 1st and is providing medically tailored meals to seniors receiving home and community-based supports, as well as those meals or medically tailored groceries to pregnant women managing any type of diabetes. The 2025 state legislative session gave $4.7 million to this effort with federal matching funds. And leading up to the go live, the Healthcare Authority really did a fantastic job in leading an implementation team. Roadrunner Food Bank and many other food and nutrition providers were a part of this team. And it met from January to September of this year. The Medicaid managed care organizations and the food and nutrition providers met separately on a monthly basis to discuss the mechanics of food as medicine. How does a prescription or referral get to the MCO and to the food and nutrition providers? Who does the outreach to the community member about the food that will be coming? The Healthcare Authority led implementation team is now transitioning to the statewide Food is Medicine Collaborative. And you're invited. We'd love for members of the New Mexico Primary Care Council to be involved. And I see a hand up. Is there a question? Sorry if I missed you. All right, Tristan, we'll go to the next slide.
Okay.
So we're here to say that with the statewide Food is Medicine Collaborative that we're starting, everyone has a role in food is medicine. As we've been sending out the save the date and the invites, we wanted to make sure that healthcare is involved, local growers and producers, public health, food delivery firms, health councils, grocers, registered dietitians. We're even reaching out to our legislators to be involved in this collaborative. Next slide. So what is our potential journey with the statewide Food is Medicine Collaborative? We may have two overarching goals to begin with. The one that I'm calling the now or the today work. And this is to support the implementation of the current program, to lift up local food and nutrition providers, local agriculture and economies towards this effort, to develop some statewide communications or maybe even potentially a campaign to let referring providers know that this program is available, to support their patients and community members, to examine food as medicine programs that are already occurring in the state and have a lot of great successful learning lessons to share and to offer. I'm learning about new ones every single day, actually. To gain knowledge about food as medicine as an evidence-based medicinal therapy for chronic disease prevention and management. I just want to note, I just attended the 3rd annual Food as Medicine National Summit through Tufts University yesterday, and a lot of really good learnings with that. So I'm missing the slides, or maybe one more slide in this, but this is some of the pieces that we want to do in the now, and the future work of the collaborative is we really want to make sure what does food as medicine look like in the state 10 years from now. I was just sitting with a colleague yesterday. It's 2025. What does food as medicine look like in 2035, and how do we get there? What's the roadmap? So that's going to be a little bit of the work of the collaborative as we roll this out across the state. So please come, you're all invited. I'll put a registration link in the chat. Thank you so much.
Sorry about that, everyone. My laptop decided to shut down. Oliver, you had your hand up. Did you want to ask your question?
Had it up to when the question was asked about do you know about food as medicine, and I tried to lower it and it wouldn't come down. So disregard it, please.
No problem. Great. Any other questions? guys. One second. Nope, that's still the wrong one. Okay. Hold on.
Alicia, would you like me to run the PowerPoint?
That would be great, Cynthia. Sorry, I'm having issues with
That's
my
okay.
screen right
So I
now.
think the next one is the metrics that matter, right?
Correct. Thank you,
Okay.
Cynthia.
Let me pull it.
Like all of a sudden now my screens want to have issues.
Mine goes out every once in a while. Okay, so metrics that matter is out.
Appreciate
Good
it.
morning. Good morning, everyone. Can you hear me okay?
Yes.
Okay,
Yes.
this is Maggie McCowan. I'm the Executive Director of the Behavioral Health Provider Association. And joining me today is Pam Stanley, who is a consultant to our project from Health Management Associates. And this project started, this is the first behavioral health driven quality metric system in the state. Was initiated prior to, well, it was launched in 2022, but prior to that, now that's, say right there, that's a good slide. Prior to that, the Provider Association, the Primary Care Association, partnered on a statewide or a national initiative sponsored by the Delta Center. And this was designed to develop value-based purchasing and behavioral health, physical care, physical health integration. And that what we found in that national project is that it was really challenging for behavioral health providers nationally to identify specific behavioral health metrics instead of metrics that were primarily physical health based. So back in right around whenever COVID was getting started or underway, and money was coming into the state, I had a conversation with the then director of BHSD, and we talked about what he would like to see some of that funding spent on. And he really wanted to see it spent on the development of behavioral health specific metrics. So we were funded by the state. We launched the project in 2022. It was really provider led. It captures real behavioral health and substance use outcomes and turns routine documentation into actionable insights. And that statement is really significant if you think about it, because what you'll be hearing from Pam and from me is that the reporting that we do, documentation and reporting that we do, is the basis for developing the metrics. So who's involved in this project? Right now, there are 16 behavioral health provider organizations across 22 of New Mexico's 33 counties, serving over 41,000 patients and 10,000 children. We started the project in 2022 with 10 providers from the Provider Association, And after 2 years, we added the additional 6. So on the screen, you'll see that we have some pretty significant participants from the behavioral health community, including UNM's Hospital COPE, Presbyterian Medical Services, FQHC, Santa Fe Recovery Center, Courageous Transformations, New Mexico Solutions, and a lot more. We have a pretty significant list with a lot of involvement. So you're going to hear today and see today some of the developments that we have accomplished, some of the things we have accomplished, and they really are significant successes. So in the first year, we developed provider metrics, provider-driven metrics. The first group of providers met for a year off and on and came up with a list that are specific to providers in behavioral health care. These measures are based in measurement-based care that is program provider agnostic. They also developed interoperability for behavioral health providers with successful data transfer into our health information exchange synchronous program. And then we also developed real-time data visible in HIE. And we have behavioral health provider access to continuum of care data. And also we developed that one of the greatest things was that we provided the platform for the CCBHC dashboards that were necessary for the implementation of the CCBHC program. So I'm going to pass this on to Pam, and she's going to talk.
Oh, sorry, Maggie. I can take back over the PowerPoint. I finally got it pulled up. So.
Okay, so can we go to the next slide?
Is this sharing correctly, or is it the wrong screen?
No, let's go to the next slide after this one, I think.
Okay, perfect.
There you go. Pam, this is up to you.
Yeah. Thank you, Maggie. Yes. So this slide depicts really the progression of what started out as the Metrics That Matter project into a program, which really is a model of practice for the providers who are participating in this program. So we started out, as Maggie indicated, with providers selecting measures that as clinicians, they knew and we know are the most relevant to identify whether or not our clients or patients are actually getting better. Then we had providers collect data out of their electronic health record and submitting that data now monthly for the prior month within the first week of the next month. So very real-time data collection and submission to the state's synchronous HIE. And then on top of that, basically developing a dashboard where you can see all of the performance for the quality measures or metrics that were selected. It's real-time data as you can see. And that allows providers, as you'll see in another couple of slides, to actually print out patient-level detail and actually have more actionable outcomes. It allows the provider organizations to look at their outcomes, not just what we call measurement informed care, where we're conducting screenings like a depression screening, but it looks at measurement over time. Is that patient getting better? And what we call practice transformation. And many of the organizations have already turned the corner and are actually working on quality improvement initiatives in their practices, refining workflows to actually improve outcomes. It's pretty impressive, some of the work that's been done so far. So ultimately, then providers can focus on improved outcomes by using that patient-level detail in the dashboards. Next slide. So this is a little bit more detail about what the program measures. You can see the core measures there: depression screening to allow for early intervention and prevention of suicides. We are measuring social needs by using the WellRx, the Prepare, or any other particular screening tool that the organizations are using for whether or not someone has housing, if they have food security, safety, transportation, the things that allow them to actually get better. We are measuring patient experience of care, or what is generally known as satisfaction, regular engagement of care, which has been a little tricky in behavioral health because treatment plans are at varying stages in progression. I think one of the best measures of the project is also time to first appointment. So we're measuring when a patient actually calls the office administratively to the first clinical visit, and measuring that along with a model we call Treat First. We're measuring avoidable hospital readmissions in just a straight 30 days. Anyone who's readmitted in 30 days, we are looking at that information. And again, the organizations have the ability to print out patient level detail. We're also monitoring crisis follow-up. So any member who's been in the emergency room for a visit for either just a mental health issue or substance use disorder, we're measuring that. And then we are measuring timeliness to follow-up care post-psychiatric hospitalizations. So we're looking at working on real outcomes, depression remission. So, symptom reduction, but also remission in a 4 to 8 month period. Successful discharges. Has a member successfully completed a program like IOP, or have they been successfully discharged from treatment altogether? We're looking at a focused ER visit reduction. And then, of course, suicide prevention, which goes along with depression remission. And as many of you may be aware, we are in the top 5 for suicide in New Mexico. We're actually in the top 3 in the world, so internationally, for suicide. So that's something that has had a pretty prominent focus in the project. Next slide. This is a really nice picture of the dashboard itself that the providers, when they go into the synchronous HIE, they travel over to this dashboard. And these are the measures that are mandatory. We had providers pick 2 process measures to monitor and then 2 outcomes measures. So they can see their performance in an individual graph. And again, that arrow at the bottom left allows them to click on that drop-down arrow and print out patient level detail to really go back and perhaps look at a treatment plan. Is that treatment plan on point? Are there additional things that need to be considered for a patient to get better? So I think really you can see at the top that we are tracking the measures timeliness-based, which is access to care, organization-based, program-based, discharges from treatment, encounter-based, and utilization-based. But all of the data is here and again able to be viewed monthly, timely, and down to the patient level. Next slide. So how is this different? We have a lot of initiatives that we see in healthcare. Typically in quality improvement, we look at claims data. There's a significant lag in claims data. It doesn't always tell us the complete picture of what is going on with a member, like a PHQ-9 screening. So the approach to the project is very different. We look at measurement-informed care, which is essentially doing regular screenings, whether it's depression, anxiety, Columbia suicide severity risk screening. But we then move into measurement-based care. So again, as the example that I gave a short while ago, looking at depression remission, by measuring PHQ-9 scores over a 4 to 8 month period. Are our clients or patients getting better? Tracking social determinants of health. One of the organizations has done a tremendous job looking at the social determinants of health and the outcomes, whether or not action was taken. They're actually to the point of combining that in a session with a client or patient, sharing with them all of those gaps that have been closed essentially, and having that be something that helps drive encouragement in the patient, and demonstrating improved outcomes, which we know does get people better. It has created interoperability by having data exchange come directly from behavioral health providers' electronic health records into the HIE. That may just be a bullet point on this slide, but it has been a tremendous amount of work. And for providers that actually have a very limited electronic health record on the behavioral health side, maybe not as robust as another physical health, EHR like Epic, it's been a tremendous accomplishment. It allows the providers also to see any bit of data that is in the HIE. So providers in this project are using the HIE, the synchronous database, to see what lab results are there, what medications have been prescribed. Let's say it's someone being discharged from the hospital. That's really important and key information in order for us to manage our behavioral health clients or patients. It's real-time data again, and it best supports clinical decision-making and allowing for us to really implement practice transformation within the organizations, so that they can really see that change and drive those outcomes improvements. Through all of this, it really supports policy planning because you have concrete real life data. And on the left, the diagram will just comment on what's inside the overlap of the circles. And that is just data-driven clinical decision-making. So a huge success in that regard. And I think, Maggie, I'm turning it back over to you for the next slide.
I just want to emphasize and kudos to the project for one of the things Pam talked about is that any program can identify their own metrics. The metrics are not set. They're based on what are measures related to that in clinical endeavor. And that makes it, it's a general kind of outline, but it really produces similar, the best kind of results. So why it matters is that we have earlier interventions with better outcomes, fewer crises, better recoveries. Again, the information and feedback about how the patient is doing is immediately available to the patient. It supports children and families with kids getting timely follow-up. It provides real-time statewide view of trends and needs. Promotes equity by tracking and implementing intervention for social determinants of health or health-related social needs. And the program has created a lasting infrastructure, that's what I was referring to, that can be modified for additional providers and outcomes measures. And I'll say that we are really exploring alternatives or different types of programs for implementing and using the basic premises of the model. And it's kind of exciting, not kind of, it's very exciting to see the potential application. It also allows providers to use data to enter into successful VBC contracts with payers. Next slide. I think that is the last one is up to Pam.
So we wanted to just point out, given the project was funded by the Healthcare Authority through BHSD, how does this connect to state behavioral health priorities? I think one of the biggest successes that we've heard from the organizations who are now have been newly approved or will be soon as a certified CCBHC provider in the state of New Mexico. The feedback is that this project was the foundation for allowing them to be successful and apply to become a CCBHC provider, which is a tremendous accomplishment for our state because it provides open access at a time where access to behavioral health services, among many other healthcare services, is really limited. And so that open access that the CCBHCs will provide is a significant success. But again, that was actually our dashboard that you saw, and the collection of measures, how to do that, was the basis for the provider's current CCBHC dashboard. It really aligns potentially with Senate Bill 3 in that it is statewide, covering 2/3 of the counties within the state. So it could easily be added to as far as providers and other measures. The state has already invested in this, and the infrastructure exists, both provider engagement, participation, practice transformation. So many components of it are already in existence. It does also position New Mexico truly as a national leader in behavioral health measurement and outcomes. Maggie had the pleasure and privilege really of presenting to NatCon, one of our preeminent provider organizations nationally for BH. They were very impressed with the project from the perspective of that it's measurement-informed care and measurement-based care. So it potentially positions New Mexico again as a national leader in behavioral health measurement and outcomes improvements. Maggie, I'll turn it back over to you.
Okay, so that is you can go ahead and click to the last slide. That is our presentation, and it's a highlight of what we've been doing, but we're very eager to answer any questions if you have any. And I cannot see that screen, so.
Looks like Michael has his hand up, so.
Yeah, so
Okay.
Dr. Bell, I'm with the Department of Health. I did have a question. Has anybody looked at provider satisfaction with the collection of these measures and the documentation of the measures? Or are the documentation of the measures done by someone other than the provider?
Pam, can you answer that?
Sure. We have done polls with the providers as far as satisfaction. Can you hear me okay?
I can.
Yes.
Great. Okay. And so the providers are very engaged in the project and very satisfied with the outcomes. Were they happy all along in the project? There were frustrations. There was one group who just could not maintain the data pool and the resources. But the organizations that have stuck with it and have been able to see the value are very satisfied with the project and the outcomes and still very engaged. I hope that answers your question.
I think it does. Thank you.
Jessica?
Yeah, hi everyone. Jessica Osenberger with Roadrunner Food Bank of New Mexico. Excellent presentation. Thank you so much. And regarding the social drivers of health, health-related social needs, and given the levels of need for food and nutrition access, is there a potential, do you think, even if you want to think about it, for Roadrunner Food Bank to support this work in some way, or to be engaged in some way?
I would say that there's absolutely a connection, and that might be something where we have a regular meeting, either the leadership team meeting within this project or program. And then we have office hours where we pull the clinicians and the folks that, actually pull the data into a discussion more for, the measurement-based and measurement-informed care. So I think that would be something that we would definitely be able to talk with you about. I know one of the organizations has done a stellar job tracking within their electronic health record these outcomes, but mainly connecting a patient to, you know, services such as Roadrunner Food Bank. So we would love to take this offline and chat with you about that. Thank you.
Terrific. Thank you.
Other questions?
Well, thank you very much for letting us present this. We've been talking about doing this for a long time, so I really appreciate Tristan staying with us and getting it. We're really at the point where we are expanding and looking at expanding the applications. And so this is an exciting step. Thank you.
John, it looked like you maybe had a something in the chat. I don't know if you wanted to, or if it was already answered.
I think they talked about it a little bit about smaller providers, behavioral health providers, and then putting data into Synchronous. And then is there an extra cost issue with some of the EMRs? Because I know some can transfer records automatically and it's not that big of a deal, but are there other systems where the costs associated to building those pipelines to get data to Synchronous are higher? Like if a person has Epic, it's no problem getting into Synchronous. If a person has Bear, it's a little bit harder to get the data into Synchronous.
So
go ahead,
Oh.
Pam.
Yeah. So, you know, there are varying costs, and one of the components of the project is interoperability. In other words, developing interfaces. EMR Bear is actually one of the entities that we have been working with through Synchronous to create that interface. There are 7 organizations within this project who have EMR Bear. So that has been our top priority to build that interface. The project actually covers through the association, the HIE participation, so which is a real gain for providers because for smaller practices, that can be an expense that they just really can't bear. And through the project, Synchronous has worked to develop those interfaces. That's actually built into the cost of the program and does not go directly to the provider, which is just pretty amazing, you know, from a behavioral health standpoint, because those vendor costs can be significant. As you mentioned, John, for any sort of interface that's developed, or really just generally setting up reporting, that's been one of the bigger themes, is that the data's in the EHR system, but the canned EHR program for BH doesn't allow for it to be reported in the way that it needs to be. And just on a final note, we did a lot of intense work initially with EMR Bear and setting up, you know, all the organizations a main reporting repository that everyone could tap into, even if they're a different organization, because they're using the same system. So it's been a lot of work. We've had some successes. We've also had some challenges, and we continue to work on those. So thank you. Great question.
Yeah, I think about that all the time too, at the additional costs for the reporting itself and being able to get the data to prove that you're serving your patients. So thank you for that.
Thanks, John. Any other questions popping up for anyone? Other discussion? Pam and Maggie, I wasn't sure if you guys wanted to just talk through some of your additional slides that you have for your maps, or if this was just for your information type of slides.
They are for your information. Oh, sorry, Mike, go ahead.
Yeah.
I was going to say it's for your information, but we can certainly talk through a couple of them. I'd like to look at a couple of the maps just to see the penetration. So this one, this first one is organizations that are participating as part of the project. And it covers we have 22 out of 33 counties. And then just as related, if you could go to the next slide, this is an overlay of Behavioral Health Provider Association members and where they are where they're located with respect to the SB3 regions. So again, a really significant penetration. And then the next slide. This is a list of metrics. Pam, do you want to speak to that at all? Is there anything that you want to point out on this one?
Sure. It's really, they're in 4 different categories, mandatory measures. So all providers in the project are required to report on the first 6 measures. Then we added the access measures of follow-up after emergency visits and hospitalizations. This was added really to kind of turn the corner and assist the providers in value-based contracting for behavioral health, which is often challenging, and solo contracting is a little more challenging to get the right model and perhaps the right rates. So demonstrating the access here has been really important. As an example, when we look at the turquoise care follow-up from hospitalization, current benchmark that the MCOs have to meet, that is 29.92% for the 7-day follow-up. And our organization, some of them have 71% success rate in 7-day follow-up. That's significant. And then other organizations maybe have lower than that, but most are actually above that turquoise care benchmark that the MCOs have. So I think that's the key component and success of the project, showing how successful the BH providers are in getting folks in within 7 days and also 30. The process measures really give us the social determinants of health status, but they also give us the measurement informed and measurement based care. And then the outcomes measures look at things that are really important. We look at depression remission, successful discharges, as I mentioned, ED utilization. That's an important component in the continuum of care and transition to whatever level of care is next. We have been monitoring deaths by suicide. That's been a little bit more challenging, but a minor success there is that the HIE wasn't getting that level of detail from OMI. With this project, we now can see not only that it was a death, but a death by suicide. And so our organizations can see that, because behavioral health patients, they're a bit transitory at times, and we lose them, right? And what's going on with them, hopefully we get them back. But this allows, if a patient didn't follow up with care, a provider organization to actually see that outcome. And I think we have one more slide here. We can go to that, Tristan. This is actually measurement-based care. Ultimately, it's showing essentially measurement-informed care. So you can just see, as the project has progressed, the level of screenings that the organizations are now doing to look at outcomes. And, like you can see, we did the Vineland, which is an ABA it's a Vineland adaptive behavior scale for young children. The Columbia Suicide Severity Scale, which is a really important scale for suicide screening and prevention. You can see how much that's gone up pretty dramatically. And then the GAD-7, which is, generalized anxiety disorder screening, has gone up considerably. This drops off at April 24. If you were to look at this today, there's a lot more progression and improvement. So again, the organizations can see month by month how they are doing. And if they do somehow have a decrease, they are actually taking that back to their clinicians individually and looking at diving into a treatment plan. They are also using this information for performance evaluations of their clinicians to see if they can hardwire measurement informed and measurement based care within the clinic, because we know that patients get better outcomes if we do that. So I think that's it for the appendix slides. But thank you for letting us present those. They're valuable as well.
Thanks to you both. Any other
Thank you.
follow-up questions or feedback? One. Okay. So we're taking our break a little bit early. I'm gonna go ahead and update our slide. Instead of 11:30, I think we can come back at 11:20. Does that work for everyone? I'll go ahead and update the slide and put it up so everyone knows what time, but we'll just take a little break. And everyone, it's 11:20. If you can start returning to the meeting, either by turning on your camera or giving me a thumbs up, go ahead and get started with the rest of our agenda. Just give us a couple more minutes so people have time to return. And if you can just turn on your camera or give us a thumbs up that you're back. Appreciate it. Right, looks like most folks are back. So I'll go ahead and pass it to our next presenters, which is Mary and Jariah. I believe you guys are going to share your own screen, so let me just stop sharing now. And thanks for joining us.
Absolutely. Thank you for having us. Yes, I can share my screen now.
Yeah, good afternoon, everyone, or almost afternoon.
Thanks, Jariah.
I guess we don't normally use Teams, so bear with me. I might
It's
be a
okay,
little
Mary.
weird
You
with the
should
way
have
I'm
seen
sharing.
all the issues I had earlier. Probably
Okay,
prepared
great.
mine, so don't worry.
Okay, unfortunately, I know I'm sharing my desktop instead of just this, but it's fine. It'll work.
Yeah.
Hi, everyone. Thank you so much for having us. Jariah and I are here from the Institute for Complex Additive Systems Analysis. We're a research branch out of New Mexico Tech, and we'll be talking about the healthcare workforce dashboard we've been working on for this past year. I'll just do a super quick little background of the project, and then we'd love to give you a demo of our dashboard and how it currently is. So, just super quick, this project was funded by the Legislative Finance Committee or by the state. It's in line item that we would establish and maintain a state healthcare workforce dashboard. And the funding is good through 2027. So that's a little how we got started with this project. This project started on July 1st of 2024. So we've had just over a year from the start of this project. The project purpose was to create a public-facing interactive dashboard that talks about the healthcare workforce within the state of New Mexico. Is helpful not only to the general public, but also to policymakers, trying to demonstrate what a lot of our stakeholders have described as a lot of hardships for the healthcare workforce within the state of New Mexico currently. For our initial first push or first year of this dashboard, we wanted to focus on trying to get data from surrounding physicians, EMTs, and nurses, and that was based on some of our stakeholder goals. Here are some of the stakeholders that we've worked with. These are people that have either given us data or tried to help steer us in the direction that we need to be going, because New Mexico Tech and ICASA specifically, we have a very long record of working with data within the state, but we normally have worked with criminal justice data. This is the first project that we've worked with healthcare data. And so because of that, we needed stakeholders to tell us who we should go to, who we should be talking to, what things we should be maybe looking at within the state. And without them, this project definitely would not be what it is. So overall, their vision was just they're trying to make New Mexico an attractive place to practice medicine. So with that initial focus of physicians, nurses, and EMTs, we wanted to focus on retention rates, or who's going to school in New Mexico, who's staying in New Mexico, how long people are staying in New Mexico before leaving, FT and PTE, and supply and demand, seeing not only how many people are currently in the workforce, but how many we're going to be needing in the coming years. So right now we have it at a 3, 5, and 10-year prediction for demand. And with that, I'll switch over to our dashboard. Can you guys see this? I think because I'm sharing my desktop, hopefully you should be able to. Good. Okay, great. So this is our landing page for our dashboard. And first and foremost, I want to mention that this is not open to the public yet. So this is, you guys are getting a little peek behind the curtains. This is still our first deployment of this. So you'll notice as we go through, the big thing you're going to notice is we're currently adapting our colors and our visualizations to be more accessible for people. However, this has messed with our UI right now. And so some of the colors are wonky. If you notice that it's weird, we're fixing it, just as a note before we continue. But this is our landing page. We have mention of the legislation down here. We have a partners page, like I just talked about, people who have helped us out, given us data, pointed us in the correct direction. We have those linked to their home pages. We also have, and I'll talk more about it as we go through the pages as well, we have definitions for all of the data sources that we're using. A lot of times you'll notice in some of the following pages, we had learned that when a data set says primary care specialists, that can mean a lot of different things. And so we wanted to know for each of the data sources what that actually means. And I'll touch more on that as we go. So the first data page is this retention page. This page, all the pages that we have this little information button at the top for right now that's stating what data is being used on each page, because each page is different and often uses different data sources. So this is using NPI data. So as we can see, currently in the state of New Mexico for all NPI, it says there are 67,000 people who hold NPI numbers. That seems like a lot, and it's because it is. That also includes people who are fixing ambulances and stuff like that. So let's filter that down a bit. Let's filter this down to just adult medicine. That's very specific. Anyway, but you can filter it down by specialty or also by classification. Maybe that might be a little bit easier to, because we can just do family medicine. So currently within the state of New Mexico, we have this Sankey diagram loaded up that for family medicine, which is what I've selected from the classification, there are currently 1,845 individuals with an NPI number that, according to the NPI database, practice in family medicine. And then we have how many of these individuals their NPI numbers are leaving the state. So after 1 year, 224 of those NPI numbers are leaving the state, and so forth, up to after 6 years of being in the system. There's only 1,115 individuals. So we understand that NPI data is not 100% accurate. Unfortunately, we have to use NPI data because we have worked a lot with individuals within the state and organizations within the state, and we have been unable to procure any data. State agencies have been very reluctant to provide data. We'd love to use other things that are more accurate, but as of right now, we're using NPI numbers. But we'd love to use something else. If any of you have information or people that we should poke, please let us know. And that goes for this entire dashboard. If any of you have feedback or individuals we should talk to, please let us know. Next is FT and PT. This is using data that it's the only data source that we paid for because, like I said, we were struggling so much to get data within the state. We paid a company called 3D Health. They were really highly revered within our stakeholders of people who had been that provide very accurate data for New Mexico and healthcare workforce within New Mexico. This is from 3D Health. This is, we can see right now we have it set by specialty groups. So for all of New Mexico, 3D Health found that for full-time individuals for all specialties in the state of New Mexico, there are 1,852 and 518 personnel for primary care specialties. Now we can break this down by region. So if we want, we can go just to, let's say, Bernalillo, and we can see that there are for primary care specialists 666 full-time and 328 part-time. So that's been very interesting to see. You can select multiple counties, you can select all counties, and then we also have just a table down here at the bottom as well for this. You've also may notice that we have little boxes here at the top. We've been our KPIs or our key performance indicators. This is, we're comparing in-state percentages, and then we have little almost stock tickers to show you what the percentage is with the US overall median. So we can see that For our percentage of FTE in all employment for New Mexico, we currently have just under like a 60 or 64-ish%, which is actually 27% below average for full-time employment for physicians within the US. And we have, of course, all of our sources notated on all of those. Next, we have our supply and demand. This is a very fun tab. This is also using that 3D health data. We can drill down and we can see supply and demand and then also our need. Right now, our need is, we have it, it's not displaying negatives. We have the fix. It's coming here in the next week. But like I said, you guys are getting a little peek behind the curtain. But we can go down. Let's go specialty, primary care specialties, and let's go just by Bernalillo. So as of right now in Bernalillo County in 2025, we have a supply of 813 primary care specialties. And as I mentioned before, for that primary care specialty group, 3D Health has defined that as, because I think you guys might be curious, we have that defined as advanced practice providers, family medicine, geriatric medicine, internal medicine, nurse midwife, obstetrics, and pediatrics. So that's what we have right now for primary care specialties. That was just according to what 3D Health, I think it's different with different organizations of how they define that, but that is how 3D Health defines theirs. We can see, and then we also mentioned before that we have the demand algorithm at a 3, 5, and 10-year rate. This is an algorithm that 3D Health has created. It's been sold to us at least as very accurate, and seems our stakeholders agree that this is seems to be accurate of what will be the prediction of the demand rate in the coming years. It's important to note that 3D Health does this. We've talked to them about it, and there's a bunch of things that go into this algorithm, but one thing they've noted to us is that they automatically will deduct providers or remove providers from, let's say if they're a provider in 2025, but by 2030, they are over the age of 65, 3D Health will automatically assume that they have retired by that point and remove them from the supply within that metric. And with the other tabs, you can click one county, you can click multiple counties, whatever you want. And then finally, we have two more. We have our nursing. This is where you're going to see colors get really weird. We have nursing, which is difficult. Nursing's in a compact. So the nursing data we get directly from Board of Nursing, but it's a little odd. We also have a Chloropleth set up right here where we can see where, of course, the density of nurses are within the state. This will be implemented on other dashboards as well in our coming release, but you know, of course, as we could probably predict, that most of our healthcare professionals are in Bernalillo, Doña Ana, Santa Fe, where we could probably predict them to be. And finally, we just added EMS data. We got this from Department of Health. They provided this for us, and so we're able to now finally see some EMS data, which is very exciting. This is something we wanted to add for a while and something that our stakeholders thought was important. Overall, that's just the start of our dashboard, but for only a year of not only collecting data, but building this dashboard from the ground up, we're pretty happy with where it's at right now, and I'd love to hear you guys' feedback.
Mary, we have a question that says, when does your dashboard go live?
It's going to be going live. We have to push out this newest update. I'm hoping we'll get it out in the next 2 weeks. So I'm hoping at the very latest by end of October, it'll be live to the general public.
John,
I see some hands raised if you guys want to unmute, maybe.
Sure. So yeah, I think this is really valuable and very exciting. You know, specifically when we're looking at healthcare shortages, there's been a lot of tension and tug and pull on the data that exists across the state. I did want to bring up one thing, and of course, this is just more, I don't know, complicating issues, but like, for instance, to consider all advanced practice nurses primary care is I think is significantly erroneous. And even if you looked at only family nurse practitioners, there's a significant portion of those that don't do primary care. They're working, you know, I happen to be CMO of La Clinica de Familia, which is a large FQHC in southern New Mexico. And, we have a ton of family nurse practitioners. And I've hired people that have done nothing but neurosurgery for years, or nothing but GI for years. And so that really, I think, it overestimates the actual primary care providers available to the state. And I think that's something that needs to be looked into and considered. And that's true in all specialties, because my family medicine doctors actually end up being hospitalists or working in the ER. But I think really thinking about what primary care is and how we define that is going to be really important, because ultimately, as Val said at the very beginning, is, primary care is the backbone of our healthcare system, and we have to make sure that we have an adequate supply and that we adequately measure that data. So yeah.
Although
Absolutely.
she said no one was sharing their data with her. It
Yeah,
sounded
so
like-
that's an issue.
I
That's
mean,
a
it
huge
sounded like this
issue.
was the only thing they could do, because
Yeah, no, it genuinely, unfortunately, because that's what's really frustrating, is that this is funded by the state, and we'd love for this to be run by state data. Unfortunately, and kind of darkly very funny, is that 3D Health Data buys from a huge data company called Milliman, and Milliman gets their data because our state agencies sell to Milliman. So we're paying for our own state data from a third party, which is absolutely ridiculous. And it's not from lack of trying. We have met with probably every organization you could think of in New Mexico asking for data. We've even gone in front of the legislative or the LHHS, and they also can't even get data. So it's, yes, but we agree that,
Yeah,
and
so
that
for-
is something why we asked 3D Health specifically who was included in their primary care specialties, because we had a feeling that this would be important and that we were overstating what
Yeah.
primary care. So this is important thank you for noting that.
Yeah, I think it would be good that if this is the data that's limited, just make sure that that's noted and as an acknowledgement in the data. Yeah, because we can say this is the best data we could get, and this is what it shows. And I think that's fair.
Absolutely. No, thank you for that feedback. I'll make sure to note that.
Yeah, we can add a disclaimer. And so for instance, like with the APCD, the All Payers Claims Database, we've reached out to them a number of times, and what we've been told is that we have to fill out a form to request data access or to request the data that we would need for this dashboard. But that form does not exist, and it needs to be created by a committee, and the committee also does not exist. And so we've run into a number of issues with that. I seem to be having internet problems. Apologies.
We heard you. It's okay. But yes, it's been, as you can imagine, a year of lots of emails.
Well, I applaud this effort, and I think it's absolutely necessary. So, and I don't know if there's anybody within our group that could help address those things, but there are two people. I know, Matt, you've had your hand up.
Yeah, so I was Mary, I was at the presentation to LHHS, and after a decade of pain on serving on New Mexico Healthcare Workforce Committee, no longer serve there. I think the reality that we're all seeing and frustrations of people like, we got to have more accurate data, is that there's many ways to look at it. There's not going to be any single way that gives us a full picture. So layering this with New Mexico Healthcare Workforce Committee, data report, annual report, and other things, I think that's the best thing you can do. There was something you said that day, and I know the legislators who were just as frustrated, many said, but as we, now we're just, whatever it is, 100 days or less from a session, some kind of, trying to put teeth to force people to report. And so anyway, I don't know if there's going to be movement, but I would definitely support any such effort on that, so we can have a more robust data set. So that's one thing. And then John, I just, so all these students I precept from all these programs, including the nursing, the NP programs, is that there's also a growing trend, which you said, where many of the graduates now recent in the New Mexico programs I precept, they're doing straight up aesthetic medicine, boutique type medicine and injections and weight loss and, stuff that, again, I'm not saying it's not medicine, but it's definitely not primary care. And so, wow, that's been a big concern for me as well. And that's new. That to me, in all the years I've given to workforce is something different. But you know, more wrinkles. It seems like the wrinkles come faster than we can iron them out.
But thank you for noting them all the same, because again, like we mentioned before, ICASA does not have a background in healthcare workforce. So this is all things, if you see something and you think they probably don't know this, we probably don't know that. So please, yes, let us know by all means.
Cynthia, or Cindy, sorry, did you want to go?
Yeah, I just have a question. So on the nursing data, does it break the nursing down by specialty? And so private duty nursing, does it say if someone is a PDN? I mean, there are RN, LPN, but do PDN work?
Don't know if it's not on this chart, then this is all that Board of Nursing gave us. So I don't see that on it. So I'm going to say that no, it is not included within the BON data.
Okay.
Is that something we should investigate about? Is that something that needs to be?
Well, there are issues in New Mexico with private duty nursing hours and being able to take care of children with physical disabilities. And what we're seeing is that there are so many of these families located in what they refer to as the frontier that they don't get a lot of nurses to go out to those locations. They're mostly in Bernalillo, Santa Fe, and so forth. I was just wondering if you collected that.
That's interesting. I have not heard of that before, but I will email BON and see if they are having to, because I don't know, I'm not sure if they have to register with BON. I'm unsure, but if they are, I'll email BON and ask about that.
Okay, thank you.
I see there's also another question about behavioral health practitioners not included. I think just on the data we were reaching out for this initial push from our stakeholders, we were trying to really limit the scope. There are a lot of different specialties we could be adding in. We could be adding in chiropractor. We could be adding in these different kind of groups that are pretty big in our state. So we really wanted to hit what we had been told was the most data rich in the area that would hopefully be the easiest to get access to originally, which ended up not necessarily being the case. So we'd love to follow up with that. If you guys have any contacts on people that you think might be able to help us get data, we would love to reach out to them, set up a meeting, explain kind of what we're trying to do. And if we need to put any like MOUs in place for data sharing, we're certainly capable of handling secure data. We can pull information about the practitioners and then remove all of the personally identifiable stuff so that the stuff that's going to the internet is not able to be hacked or, dox people or release any information that needs to be secure. ICASA has a pretty long history working with like three-letter agencies. We really got started doing critical infrastructure, like electric power grid and how do you secure that. And so we have a lot of history in the security space, so we're able to handle stuff that's a little bit more sensitive. I see another hand raised.
Well, it's super important, but again, back to New Mexico Healthcare Workforce Committee and my previous recommendation that somehow we need to combine efforts or at least have dual representation. They have got a separate behavioral health workforce subcommittee. First name I would think of would be Dr. Bonham, but somebody reach out because there's maybe ways that we could better put that data set, and link things together is one thing. But it just brings up another, as my current student, UNM NP student that's finishing her clinical rotations, gets geared up to go on for DNP, and she's going to do psych. So psych DNP, right? And we have that program at UNM. And so I think, one of the challenges there, and right now, some of the concerns that I'm hearing from legislators about the funding boxes, right? So we have the, SB 1.3, all of that, but funding box. So who's included? I know I write a lot of prescriptions for behavioral health, including buprenorphine. But am I not a behavioral health provider? Are DNPs in psych behavioral health providers? Like, again, where you separate that out. And I think it's important in two sets. It's important on the data, and understanding, especially in rural and frontier, we wear so many hats, right? You know, coming from the one-time rural mental health provider of the year, as a PA, I had never considered myself a mental health provider until they said, Matt, you don't screen for, diagnose, treat, prescribe for mental health conditions. Yes, I do. So that changed my viewpoint. But I think on the funding side, because as these funding sets come out, you know, we may be boxing in things that may not be as relevant, particularly when we get into rural settings.
Yeah, that makes sense. And is the report you're talking about the workforce report out of UNM?
Yes. So understanding the background of that, that's a LHHS, as you reported to, that's a mandated statute that you know, it's an unfunded mandate that New Mexico Healthcare Workforce Committee, you know, meets and, you know, through UNM and provides those reports. And so that's, again, to me, it's a two side-by-side efforts. This one in part made because people didn't feel as confident and I don't blame them, neither did I, in the other effort. And all I'm saying is they should not just be running laterally. They need to somehow come together.
We've met a lot with.
Happy to be a part of that.
We've met a lot with UNM over this past year. Unfortunately, because of the state mandate, they are actually not allowed to share any of their data. It's actually written in that they are not allowed to share any of it. We've worked with them and they've been very helpful in pointing us, you know, where they think we could be looking. But unfortunately, any data that from the state that's shared with them, they are unable to share, which is unfortunate. But we have been working with them over this past year, so
and they are a stakeholder on our regular meetings.
Yes.
Yeah,
and so
and,
we are
well,
definitely
they are.
keeping.
Yes, and I understand that, but I think again, the overall New Mexico Healthcare Workforce Committee, you know, people automatically say UNM, but it's much bigger, and including there is a subcommittee. Back to the point here is for behavioral health specifically and behavioral health workforce data. So yeah, I just think there's another example as we get ready to go into another session of low-hanging fruit, that statutes that need to be corrected. How stupid is that? It's almost as stupid as paying twice, paying for data we already give somebody and let's pay the third party to get it back. So anyway, those will be, I'm taking notes and things I'll be recommending the legislators to try and fix for us.
That's fantastic. Yes, we agree. We would love to have that fixed as well.
And if you have contacts in those groups that you think you could pass along, we'd be happy to have that passed along and start maybe briefing them on the project and seeing how we could partner together.
Sure.
Let's see, did I miss any questions in the chat? I don't think so.
Michael, will you email me so I can just connect you, use that as a springboard to connect you to those folks?
Yeah, we can reach out to you if you're on the invite, or if not, then I bet Tristan can give us your contact.
Thank
Matt's easy to find. He's all over the place. So.
Oh, okay, great. Then I'm sure you'll be hearing from me in the next
But
day
no,
or
I'm
two,
happy to
worries.
connect as well. So.
Thank you so much.
Any other feedback or questions?
Okay, well, thank you guys so much for your time today. We're happy to present, and you know, we really do want to make something that's useful to the state, and so your all expertise is what helps us do our job better. So we appreciate your time and your input. Once we roll this out, we can try to send out the link to you guys once it's open to the public, and then you can just email us your feedback. That's kind of the thing. We do the technical work, and then we work with the subject matter experts to make sure that things are in tip-top shape and we're getting all of the definitions correct, and making sure that all of those little nuances that you guys have keen understanding in from working years and years in this field, we can try to translate that so that this tool is actually helpful, not just to you all, but to the general public to understand where we're at in the state, and then to legislator members so that they could see like, oh, we actually have these problems, and hopefully if, you know, if this continues into the future, we would have access to historical data And then you'd be able to look back and say, hey, did this legislation actually impact positively or negatively, is kind of the goal that we'd like to have, is an actual tool that's long-term helpful to the state, so that everybody can be on the same page. So thank you so much for your time today.
Yes, thank you all. We really appreciate it.
Yeah, thanks. Mary and Dre, I just thought too, it might be helpful if you put your emails in the
Oh,
chat too, just in case
absolutely.
folks want to reach out to you
Sure
directly.
thing. Thank you.
That'll help my email inbox as well. So thanks, Jiraiya. Okay.
Okay, well, have a good rest of your day, y'all, and hopefully connect with some of you and start making some more connection in the state.
Thank you guys.
Thank
Have a
you.
good one.
Thank you
Bye-bye.
both. All right. Oh, we'll keep moving along. Let's see, John, I think you're up next. Let me share your slides. You see it?
Cool. Yeah, got him. Yeah.
Cool.
So it was like totally perfect that that report went out first, because first of all, this is about low-hanging fruit. See that, Matt? It's low-hanging fruit. So I wanted to share that with you. This is the Workforce Committee report, and really what we're talking about is what can we do as a Workforce Committee to address our workforce shortage issues. We had talked about, and a part of the 5-year plan that we had with the state was about collecting data. And obviously we can see that continues to be an issue, and we continue to work on it, but we're making steps forward. And I think that's huge. But instead of just waiting for data, we know we have a workforce shortage and we need to take steps to address that. And so the Workforce Committee has gotten together and talked about 3 areas that we can address quickly and hopefully make a difference with workforce in primary care in our state. So the 3 areas are increased loan repayment, and we'll talk about that real quickly. Invest in the stability of current primary care training programs. We continue to work to build primary care training programs, but unfortunately, we've lost primary care training programs, and we lost new primary care training programs. And how do we stabilize that? We need to continue to train primary care providers, and we need to make sure those programs are stable and able to move forward. And then last but not least is promote primary care. And that has become one of my biggest things as of late, because all of us on this committee, we really understand what primary care is, but I don't think the state does. I don't think our legislators do. I don't think the governor does. And I really, really think that we have to make sure that people understand what primary care is and how important it is in the state, so the state can adequately invest in primary care. And that's why we exist. All right, next slide, please. So first low-hanging fruit is increased loan repayment. I didn't know this, but did you know New Mexico has the lowest loan repayment in the country? Out of 50 states, we pay $75,000 payable over 3 years. That's $25,000 a year. It was recently $50,000, which was over 2 years. So California, Massachusetts, Michigan, Vermont have the highest at $300,000 a year, and they vary anywhere from 5 to 10 years for loan repayment. The average student debt across the country is about $250,000. I think it's $251,000. And we know, especially with private for-profit medical schools, many students are graduating with $500,000 or more in debt. And the $75,000 just is not attractive. And we need to figure out how to do that. So next slide, please. And I'd love discussions with this too. So what we'd like to do is have this committee, the Primary Care Council, produce and distribute a white paper specifically on the need to increase loan repayment. We would like the increase from $75,000 to $200,000. We would like to increase the years of service from to be at least 3 and maybe up to 5. And so why do we do this? It's really important to understand the longer a person stays in the state, the more likely they're going to stay in the state. It's a retention strategy, and there's really good data that if you do loan repayment for 2 years, you have less people staying in the state than if you have loan repayment for 5 years. Some places are up to 10 years. And this $200,000 can be payable annually. So they get a piece of it each year they stay. And the sum increases annually to a total of $200,000. So when they stay if they finish their 5 years, they get the whole loan amount or the whole loan repayment amount, which is huge. So I think creating a strategy that states this. When we create this paper, we would love to have other organizations, including the New Mexico Primary Care Training Consortium, the New Mexico Primary Care Association, the NMAFP, the New Mexico Academy of Family Physicians, the medical societies, GAMA, UNM, BCOM, and other people sign on to say, hey, this is important. So the state needs to move forward with this. I can tell you legislators are in favor of this. I can tell you I've talked to the New Mexico Primary Care Training Consortium. Actually, I haven't. I've talked to the New Mexico Primary Care Association. They're in favor of this. And I know there's members of the NMPCTC and NMAFP on this call. And I think those would be supportive things. And then jointly send to the legislature. So this is one thing I would ask that we would move forward with. I'm looking at Val. Val, do we have to have a motion and all that kind of stuff, or I don't know.
Yeah, good question. I'm not sure we would just for a sign on. I think that'd be okay.
Okay. Matt, I see that you have your hand up.
Yeah, I just want to make sure I fully understand. So I am a New Mexico Loan for Service recipient. For me as a PA, that was $30,000. This house I'm sitting in right here is how I was able to put a down payment on it, and 22 years later and still here serving. So I think it's super important. Definitely this is near and dear to my heart. I think the broader we go, the more support we'll have. But, again, I can't tell that story if this doesn't include PAs. So I don't know if there's are you just going to do physicians, or are you going to include the other provider types that are already paid for with the state loan for service?
You know what? We haven't discussed the intricacies of that at all, quite frankly. I think ultimately it's primary care. And if you're a primary care provider and you're serving in a primary care portion of the state, you should receive loan repayment. And I think that's really the direction we want to move. And I'll talk about that a little bit in the upcoming slides, which is slightly different, but really PCP investing in how we continue to grow primary care. So,
that helps me a lot, in terms of me being able to put my strength behind this. As a PA, this is PA week, so especially as I get to present that with the AAPA sponsoring the NASEM conference, I'm presenting that next week. And so I think that's huge. And so it would just change I know we got to be careful with our definition, but from primary care physician to primary care provider in terms of state loan for service.
Absolutely. And again, I think as long as we focus specifically on primary care, that's really important. So I don't think a title like a FNP or a family physician necessarily means primary care. If they're providing primary care, then they would be eligible for that. So that would be my recommendation. So the next step is really invest in the stability of our current primary care training programs. I think we've really focused on opening new training programs. And why have we done that? We have done that because we know, based on years and years and years of data, that where a person trains is where they tend to stay, right? And so if you can open a training program in a rural community, they're more likely to stay in that rural community. The problem is those rural communities, those FQHCs, critical access hospitals, et cetera, are fragile. And many times the fragility of those institutions puts the training program at risk. And I would like us as a primary care council, specifically as a committee of the primary care council, I'm the chair of the Graduate Medical Education Expansion Board, to work on how we do that. So we would work not on expansion, but on stability of the programs. I think anything that's under expansion at present, we continue to work on that. I'm not saying stop the work we're doing, but I'm saying we really need to think about where we are. And we're actually probably reaching saturation as to locations that can actually support programs. I put in here support the consortium model for current residency programs. And I think we have the New Mexico Primary Care Training Consortium, which has been central to a lot of the work being done. But I think the consortium model needs to be significantly strengthened because I do not feel that the consortium model as it exists today has enough strength within itself to help support programs. And really trying to figure out how we can do that. And I'll give you an example. This is like a lot of times the programs close because they don't have any faculty. And could the consortium actually have a locum tenens faculty where people were able to support programs while faculty are being groomed or grown or recruited or et cetera. Just other things, but that's a big ask. And so we need to really support that. The next thing is support expansion and stabilization of residencies and FQHCs. And this is federally qualified health centers, community health centers, and I also say critical access hospitals. And the way we stabilize that is by funding. And we have a funding source through the state, through Medicaid, that only pays for half of the cost of the resident. If we could establish a program that covers the entire cost of the resident, it would more stabilize these programs. The next one is explore using fundings for other types of providers in primary care. And this is, Matt, this is to the point I was talking about. You know, I really think working with the state, and I've actually had some discussions with the PCA specifically about expanding residency programs for nurse practitioners and PAs, et cetera, providing extra strength and extra quality to the providers in our communities. And I think we need to think about that and how we support that. Because I think if we support these providers in these training opportunities, they're more likely to stay there instead of do boutique medicine. Because I think they'll be more prepared to handle the complexities of the patients in our communities. And then the last one is determine HB 480 and HCA alignment with sustainability, because a lot of what we've done before is growth, but not necessarily sustainability. And how do we sustain these programs, I think is a key component that we need to think about. And next slide, please. So this is verbiage from House Bill 480. Can you go to the next slide? There you go. And so in section 4G, it reads, the Secretary of Human Services and the Secretary of Higher Education shall assist the Graduate Medical Education Expansion Review Board in developing a strategic plan for the expansion of graduate medical education training programs, which shall include the following: ongoing evaluation process, and the last one is a plan to ensure long-term sustainability. And so it talks about developing a plan, but it never says in the language per se that this funding should go to sustainability. And I think what we need to do is really think about how we talk to the legislature and the secretary specifically about maintaining sustainability of our training programs. So before I go on to the last one, I was going to ask, does anyone have any input on this second low-hanging fruit about trying to sustain and maintain our current programs? I see a thumbs up. Okay, so that's the next step. We'll move forward. And then the next one is kind of my new favorite thing. We discussed in the meeting holding this for 2026 action, but I'm thinking because of the general session is different this year, obviously it's a short session, and we could think specifically about funding our other opportunities. But, you know, this is a quote: high quality primary care is the foundation of high functioning healthcare system and is critical for achieving healthcare's quadruple aim. This is a quote from the National Institutes of Science and Medicine, a report that was implementing high quality primary care that was published in 2021. It basically says, as Val said at the beginning, primary care is foundational to what we do in maintaining a high functioning healthcare system. The second quote is, primary care is the only healthcare component where an increase in supply is associated with better population health and more equitable outcomes. And notice it says the only healthcare component. No one else has been shown this, right? And I think that's really important. People will make statements saying, well, we need X specialty, we need Y specialty. And I'm not saying we don't, but if we're going to really associate better population health, more health equity, we need to have primary care as our foundation. So show the next slide. So I don't believe that our community as a whole really understands this, nor do I believe that our legislators understand this, or our governor, et cetera, understands this. And I think that I would like us to really create some sort of marketing educational material focusing on the public, lawmakers, and medical students as well, so people understand how important primary care is. Because I think unless you understand the importance, you're not going to invest in it. And I think we need to have people really understand that. And it just needs to be something that people know. So what does the committee think about this as a low-hanging strategy, as a fruitful strategy? When should we, or how should we move forward with this? Matt?
I paused because I didn't want to talk so much and be first again, but I'm so excited. First of all, you guys got to get me in on these subcommittee meetings. I got to figure out how I can be with you guys, because this is it for me. This is what makes me tick. So I'm all in. I guess the first thing I would say, I'm curious. The second quote, the first quote you said was straight out of NASEM, and the second quote, where is that from?
Same place.
Could we go back? It is okay.
It's actually from the same place. Yeah,
I want
it's
to use
from the
that
same
in my
place.
presentation.
Yeah, it's from the same place.
Yeah, so I'll be presenting there, as I said, on Tuesday, and I'm actually going to use this with better population health. Let me put that word in. But yeah, in my presentation, I say, access is the answer. The workshop's about, improving diagnostic excellence in rural health. Well, you don't get to diagnostic excellence if there's no access. And that starts with primary care. And of the many things I do as, thinking myself as a mental health provider, as a PA, primary care PA, is I also refer to behavioral health therapy. That was the start of my day, is making sure these two patients that I saw at Petco School-Based Health Center Tuesday got appointments. That's how I started my day to day, and not just made the referral, but made sure the loop got closed. So I think, that access point, also back to what you said, John, of saying, it comes up, we need these specialty cares. We do, and I love that you said that, but you never get there if you don't start with primary care, right? For many of them, for whatever reasons, the structures, we could argue if it's right or wrong, but you need a referral from me. So many times people are just seeing me, they're like, my insurance says I need a referral from you to see the podiatrist, but so there's that. When patients know where they need to get, but they need me to do something so they can actually get there. But so much of it, and back to what you said, that primary care relationship, it's a relationship. All healthcare is, but especially primary care. And you really, when people don't know what they need, and you're able to get to know them in a relationship of primary care, and then really get to root cause of symptoms, and then be able to make referrals, right? So specialty care needs us too, because you don't identify you need a nephrologist or a psychiatrist or a neurologist or whatever it is without that. So I think, whatever, back to the last slide in the marketing, yeah, that whole dynamic, I completely agree. There's a lack of understanding of, and so I'm all for all of this, including some marketing strategy to help folks, the powers that be, and the future workforce, and the people we serve understand.
So I think with the workforce committee, we will work forward with Val and the rest of the team on how do we create this marketing strategy? What does this look like? And, and present that forward, because I think you're right. It's absolutely important. Jessica?
Yeah, thank you, Dr. Ansola, for this wonderful presentation. And I agree with Matt, as I'm looking at the previous slide, that is just absolutely incredible. Thank you for bringing that forward, and something I very much support, even coming from food bank side of things. I serve on the equity work group, and I'm wondering if there is a place or role for this work group to help with some of the creation of the marketing and the educational materials. I guess I'm kind of thinking about it in my brain too, as we're trying to launch the statewide Food is Medicine collaborative, and getting a really good kind of communication campaign, whatever we want to call it, out there. It's very much in my mind, but I think our equity work group meets soon. Maybe Tristan, maybe this could be a topic of a conversation. And maybe there's even some cross collaboration that happens between the Food is Medicine collaborative and this kind of work with the equity work group, and just the materials and the getting the information out there. So, and also I wanted to focus on the second bullet point, particularly concerning medical students. Believe it or not, Roadrunner Food Bank has a lot of medical students that come through that intern or spend some time with us, whether it's a volunteer opportunity, they're with us a little bit longer, as do other CBOs. So I definitely would want to kind of put a plug in that the CBOs can help with some of that messaging and that communication as they're interacting with medical students as well. I think that is incredibly important, to have that kind of layered messaging. But I really would like to see what maybe the equity work group of this council kind of thinks, and how we can support and help. But thank you for bringing this forward. It's definitely got me a lot of wheels running.
No, absolutely. And I think, we're going to have to be able to approach this from various angles, and I think it's a workforce development thing, but I think it applies across the board for our public health, quite frankly, and population health. So yeah, I think I would love the equity work group to help us with this. Absolutely. Val?
Yeah, thank you so much, Jen. That was really a very good presentation. And again, I think it's just awesome to see the work groups, putting forth specific action items and next steps. So it's really great. The past couple of months, I guess, since the National CHC conference, I've also been referring a lot to, the same, particularly the second quote there, in circles where I thought that the value of primary care was well understood and no one would be surprised, and people are still quite surprised. So it's definitely not as well understood as I thought. So that's been really enlightening. And I think that, it's a really important and, sort of urgent time to get this message out, particularly with, coming threats to Medicaid. I think that New Mexico's done such a fantastic job of increasing Medicaid payments to 150% of Medicare for primary care, and that's significantly threatened, I think, currently. So I think it's a really important time to be getting this message out. This is sort of a a PCC structural question for the HCA folks, but what's the a media campaign, right, takes resources and people with good graphic design skills and money. Are some of those resources available in partnership with the HCA, or how do we go about sort of the funding / logistical structure for that? John and I can make flyers, but they won't be nearly as good as if it's professionally done.
Thanks, Val. You know, I'm not completely sure. I was trying to see if someone else from HCA might have more knowledge. I'm still pretty new to Healthcare Authority as far as what's available. Oh, I see Alana. Alana, do you have any thoughts?
Yeah, sorry, tell me again, and I'll.
Media campaign as far as how much that could cross over to these efforts by the Primary Care Council.
Potentially we have some media folks in Medicaid, media folks in Healthcare Authority. It would just be something we'd have to coordinate.
Yeah.
Okay.
Yeah, I can start querying Val. I'll put it on my list.
Thank you, Tristan.
Yeah.
So, this is just a summation of the action steps from the work from the working group. We're going to create that white paper. We'll make sure everybody knows. Well, the Graduate Medical Education Expansion Board really needs to focus on stability, and I think that's something that we'll talk about coming up soon and what that means. We might need to talk to the secretary about using funding for stability specifically, and then create a strategy to promote primary care, and that's what we've been talking about. So thank you for the participation, and we'll keep everybody in the loop as we move forward.
Thanks, John. Just going to pause one more minute just to see if anyone has any other thoughts. Fun. Let's see. I saw your comment, LaDonna. I don't know if you wanted to say anything about what you had put in the chat.
Thanks, Tristan. So some of you don't know who I am. My name is LaDon Woodson. I work alongside Tristan with the Medicaid Advisory Committee, as well as the Beneficiary Advisory Council, and I'm the business owner for the closed loop referral system here with HCA. And so as I was listening to both John and Matt and some of the comments that you made, thinking about how we can incentivize staying in the state, thinking about ways that we can ensure that some of those loops are closed as we're looking at moving from primary care to, if you have to go to your primary care, you have to be referred to a podiatrist. Well, you also may be finding out that they need other social determinants of health issues, such as food and housing and things of that nature. So I would really like to see, as we're discussing these kind of things, how we can intersect using the closed loop referral system. I know some of you are involved with that already, like Jessica's and others, and just seeing where we can use the prospect of doing something that's statewide that crosses some of these barriers as a way to incentivize, as a way to kind of push some of these agendas forward as we're still building on that process. And so that's why I put that in the chat, because I think this is an opportunity to really build something that can benefit across platforms if we do it right. And if we are all at the table and kind of thinking through this from that more holistic lens. And so that's why I put that in the chat, just to kind of put something on your mind as well. Go ahead, Matt.
So I was a big part of, as a former exercise specialist in my first health career, the whole exercise is medicine push from the American College of Sports Medicine. And so we did implement that here at Highlands University. And then I could write a prescription as a primary care provider working in the Highlands Student Health Center for exercise. And then they would be able to utilize the Wellness Center for free. And then, I think back to what you just said with food, I can't tell you how many, farmers market food vouchers I've given out as a primary care provider, because I could do that, right, as back to the social drivers of health. And, I didn't preface why I was asking Alana about the visits, but the hub and spoke model, which is phenomenal data. Again, if you guys can come to the presentation on Tuesday, you'll hear more about it. But 10,000 of the visits from the New Mexico hub and spoke model that we've implemented for school-based health center access, which will now be expanded to senior centers thanks to Anchorum Health. 10,000 visits are CHW visits. And those were non-billable at the time, unfortunately, shucks. But, you know, the point is the work that it's there. And as Jessica knows, the whole kind of that key component of having that built into primary care. So you're identifying those social drivers and resourcing those social needs. And I think the most interesting thing to me about this whole process is how now for the Semillas de Salud program that we're fleshing out better through the Office for Community Health at UNM is, you know, now there's a fourth component, which is also addressing the social needs of learners, because in getting people interested in healthcare and getting them to, you know, to the level that they can, you know, apply for a BAMD program or any other program, CHW certified or whatever, they're under-resourced New Mexicans too, especially those from our rural and underserved communities, and they need food and housing and transportation to be able to stay on their pathway and complete. So it's just a wonderful point there. I wanted to let you know how my role as a primary care provider, I mean, it really has become, as Dr. Kaufman would say, 80% of what I do is to impact somebody's health. You know, 20% is writing prescriptions in the clinic, but it's really coming together. And I think that could be a huge measurable impact over time.
Jessica?
Yeah, I love all these fantastic comments, and it really is just jogging so many different things. So maybe I'll just make a quick statement here. That it happens frequently in food distribution, in my experience at Roadrunner Food Bank, in which we are interacting with individuals who've had no to little or zero access to anybody in healthcare at all. And it's gone on for quite some time. And so a lot of times we are in the role, particularly when somebody's identifying to us that they may have a medical need, whether it's for themselves or somebody in the household. Oftentimes we're in the role of trying to help people reconnect or reestablish to healthcare with primary care. And that there's different kind of actions that we take towards that, but we are oftentimes sort of the explainers in these situations as to why primary care is so important, why having the connection to healthcare is so important. So I definitely just want to kind of reiterate that in this work going forward, number one, I'd love to be involved. I'm very interested in all of this, and just to really look at how much that the CBOs can really support this. And as the statewide closed loop referral system is rolling out and so forth, I think there's a lot of opportunities. I really appreciate that remark, LaDon. I love it very much. And I think that there's a lot of ways that we can intersect with that system. So just wanted to kind of put a plug in for this as well. Thanks.
Thanks, Jessica. Anyone else? No? Okay. I'll introduce myself. That's myself. As you all know, I also oversee the primary care payment reform. And we were supposed to have a kind of update on the new turquoise claims database, but that did not work out. So I thought this was a good opportunity for us to provide an update since we didn't at the last quarterly. And I've also got Margot and Craig here from our HMA team, and they can just help me along the way if there's anything I might need some help with. So those are just some of the topics we thought we would cover today. There's a lot. We've been very busy, that's all I'll say. really trying to finalize our quality measures. We have a bit more also for the rollout of the patient experience of care survey. And then talk about a little bit about SBIRT, but some of you might already kind of know what's going on with SBIRT. Talk about bonus payments, our evaluation of the program, and then just kind of some upcoming items for the program. So as I mentioned, we've been very busy. What we've really been busy with is finalizing our quality measures for this program. And so this slide just really talks a lot about the various influences to this. And so certainly some people are probably registered in the program or know quite a bit. And really providers have wanted to know what these measures are for good reason. But these are kind of all of the different factors that have really, I don't want to say complicated, it's just made it much more complex than one might think. So obviously gathering all that input from providers, keeping that really as our central focus, but really trying to make sure that all of our measures not only focus on process and outcomes, but as well as access and person-centered measures. So as you heard from Maggie and Pam, they have very similar kind of plethora of measures. And obviously another area we really wanted to focus, mainly because there are areas, you know, in New Mexico where we are lagging behind the national benchmarks. And so a lot of those are already included in the Turquoise Care contracts. So we just wanted to make sure that rather than overburdening providers, right, and having so many measures, that many of our measures are really ones already that are in the Turquoise Care contracts. So that was another area we really needed to look at. And then, of course, the other ones, which are mainly administrative, right? There's a lot of changes with the NCQA standards, getting our approval from CMS and other things like that. So we're going to share a bit on what the measures are, but I'm just going to show you first what our timeline is currently. So if you're familiar with the program, you probably already know about the 4 that we have been implementing with the program with providers. So this is the third next available appointment, the patient experience of care, SBIRT, and patient encounters. So that has continued. What we're planning to launch in 2026 is 2 new structural measures. So these will be the certified electronic health record technology and interoperability is what we're calling that one, and the clinical quality improvement. And then we'll also have the 10 new clinical measures. But just a reminder, mainly we will be rolling them out, but it's just to get a baseline. So again, we're just monitoring them. They're not going to be tied to the payments, but obviously we need to get a lot of these baselines for measures to really even start with the pay for performance. And so that the plan is still to launch the pay for performance with these measures in 2027 and going forward. So that's the timeline for measures. This is a list of the current quality measures. And so this is most current. As it says below, we've really been discussing these extensively and really trying to hammer this out because we know this is really important to providers. So it may change. Obviously, we still have to get CMS approval. But these are what we currently have. So just starting with the green box, so that's obviously our access and reporting measures. And these are the ones that I just shared, but we're already doing. So obviously we will continue to ask providers to share on these measures. In the yellow box, that's our clinical quality and utilization measures. And so just to note, when we started with this, we were really hoping to stick to HIDIS measures. And I think I don't need to explain why that, that was so important for us to stick to. Unfortunately, because of the way things have been happening on the NCQA level, and with HIDIS, we've had to modify some of these to be state-specific measures. So they're grounded in the HIDIS measure, but we're going to have to go forward and really create a state-specific one and ask for approval. And I'll talk a little bit more about why that is specifically on the next slide. And then again, the 2 structural measures that I mentioned that we'll be doing in 2026. And I'll talk a little bit more about those in a couple slides. So there's a lot of reasons behind this, but these are really the 2 main reasons that we've had to kind of pivot with these state-specific measures. So obviously there's been a lot of substantial changes with the NCQA, and the main one being that they're really shifting the reporting method to this ECDS, or Electronic Clinical Data System. So right, that's EHR, EMR. And so that's a huge issue, right? Because we know there's lots of primary care providers in our state that don't have EMR, EHR. And so that makes it really difficult for them to report that data. So that's why we've really been trying to think, practically speaking, for New Mexico, that we need to meet people where they're at for right now. And then, hopefully as people build their practice and their abilities, we'll be able to shift more to those other measures. The other one is obviously the quality improvement. So we know it's really important, right, that people use a lot of these incentive payments to improve their practice. And really that's because it will help improve the amount of bonus payment they'll get. So that's really why we've decided to go this route. Lost my mouse, there it is, okay. And so then just a quick update on the patient experience. So we are going live next week with the online survey that NetHealth has created for us. And so there's 2 different options that providers will have. Option A is probably the simplest, is they'll use the unique survey link through the web application, have an iPad or whatever it may be, to just directly provide that to patients to do the one. It's a Likert scale, basically just asking if they would recommend the practice, I think, to family members or friends. Option B, it's a little more complicated, but we created this because we've heard from a lot of providers that they want to continue with their own process. And so we have a template that will be available to them. And so they can kind of incorporate that into their own surveys that they're doing. Let's see, for Q4, the measure won't be calculated, but we're just doing it to really start to make sure that there's no bugs, right? The implementation for January 1 will go smoothly. So again, we're just encouraging providers to start incorporating it into their practice just to make sure things are running smoothly. And then we'll just start looking at the numbers and see where we're at. We know it's not going to be perfect, but at this point, we're just trying to get people get them started with the survey. So for SBIRT, as some of you may know, we had to pause the requirements around that. We were supposed to, I think in October, we were supposed to be fully implementing, meaning providers and practices were trained, all their staff were trained, and that they could start implementing it. We've had some issues, obviously, on the state level with having a contracted trainer to provide this. So right now it's still on pause, but we're hoping that we'll have kind of a temporary contract for the meantime. So folks that maybe they were in the middle of training, we've heard that from some providers, they can complete it with the rest of their staff, or other folks who just, are ready to start implementing, they can go ahead and do the training as well. But we're really trying to, I guess, refine the way the training's done. The prior model, we've heard a lot of issues with it and how long the trainings were, obviously how many staff need to be trained, things like that. So I'm working really closely with BHSD so we can make sure that this meets the needs, not only for primary care, but obviously we have maternal health and some other providers. So we're going to be really pivoting to more of like an online training model where it's a bit more self-paced, not as time intensive, and kind of meets those concerns that we've heard from providers. And so this is like the greatest slide, 'cause it's all the good news, right? Our payments are coming out. So I've already heard from providers that for calendar year 2024, they've already started getting the payments. I believe the MCOs had till the 20th of this month to get payments out. But it looks like that's already happening. And we're in really good shape with our what they call the preprint, which I find such a weird term, but we've already got approval for 2025 and already starting to do calculations for the first quarter. And we're working to get our approval for 26. So hopefully there won't be any further delays. To me, that was kind of the most important thing when I came on board, was just, we just need to get these payments out. And so hopefully from here on, it will be much smoother and not as many delays for providers to get paid. So we've also been finalizing our evaluation plan. This has also been very time intensive. But again, it's really important because CMS really does require for all state directed payments that we have a solid evaluation plan and provide that to them. So really it just is, focuses on the successes of the program, sees what the effectiveness of this program is as far as improving quality and outcomes, things like that. What else? I mean, there's a lot of different ways that we're doing this. Obviously, there's surveys, focus groups, and so it's a blanking on the word, but multiple ways that we're gathering this data for our evaluation plan. And so, yeah, we'll be happy to share more of the evaluation as we learn more from the program. This just talks about kind of some upcoming things. So you might have seen on our website, we're going to be having our in-person workshops again, right, which we've done pretty much quarterly. So it'll be at the end of this month. We're changing a little bit of the style of this. If you've done them before, you probably knew we were doing them kind of all over the state to try and meet people where they're at. But I think what we've learned is people are pretty accustomed to coming to Albuquerque, and that's been my experience also as a New Mexican. So this time we'll just be doing 1-day workshops, and we'll be doing 2 of them in Albuquerque. So you can find all the information on our webpage and to register. So we're just really encouraging everyone, especially folks who maybe are not registered and just interested in the program. It's a really good time to just come in, start getting these payments before it's tied to pay performance. So also we'll be doing site visits in Gallup and Taos. During that same visit, the HMA team will be here, so they take the opportunity to meet some of our providers who are registered. And again, we're building the plane as we're flying it, so those site visits really help with that. And then we're also finalizing what we're calling our launch conference, since we'll be going into phase 2 of this project in 2026. It's just an opportunity for us to celebrate this next kind of phase of the program. And then this also just has information about the upcoming webinars that we have monthly. And again, you can find all this information on our website. And office hours, we know Jen Stinnett was on here. She's like she comes to every office hour, but just a reminder also that we have those every 2 weeks. And you can register on the webpage if you're not already receiving those. So again, this is just the highlights about what will be in our live workshops at the end of this month. It's still a evolving agenda, but these are just some of the topics that we've put on there. I think even since yesterday, we've thought of some other things to add to this agenda. Again, just more information about other activities we have going on. We're still working through patient assignment and attribution. It's another one where we've had to step back a bit because you learn so much, I'll say, when you do this type of program, and that we're really kind of leading the way for this type of state-directed payment. So we're working on that. We're hoping to share with providers very soon. I think we're in the final stages of what the guidelines will look like for the MCOs. So we'll be sharing that soon. Provider outreach. Yep, we just recently did some outreach to providers who had registered, however, have not provided the data or anything like that. So again, just to see what some of the issues, barriers, challenges are. We've done that and already starting to develop some plans around that. We also have some promotional videos that will be coming out. I think we're going to have 8 or 9 this year, and some have already been developed, and we'll be releasing those soon on these various topics, and also a resource library. So you can go to the website, and we've got stuff there already, but we'll just keep building it and adding more in as we go. So that is it for the PCPR updates. I'll just pause and see if anyone has any questions, thoughts. Wow, nothing? Shocked. Maybe that means we're doing a good job, Mario and Craig. I mean, we've been, I'll just say the HMA, we've been working very hard on getting a lot of these things figured out, so we can start sharing with providers. But it is very, very complex. Let's see if there's something in the chat. Oh, thanks, Jessica. Thought it was clear as mud. Okay, I'll move on. Val, I don't know if you wanted to start us off with just any comments, thoughts, things like that.
Sure, yeah, and I think it's exciting to see the things happening across a number of different domains of the PCC, and as always, to see the hard work and support that the HCA and the state are doing in support of primary care. So big thanks to everybody for spending a large chunk of your day with us today. I know these meetings are long, but there's so much good information that it's really helpful. Again, I'm encouraging the work groups to continue to meet, and with a goal of creating sort of 1 to 3 or 4 action items and clear next steps. It would be great if we could report back on those at the next quarterly meeting and see how we can help drive some of those specific initiatives and specific action items forward. Thanks again to Dr. Andazola for sort of showing what that looked like on the workforce side. All yours, Tristan.
Thanks, Val. So yeah, this is kind of our standard slide. Obviously, we have our various work groups going on. And if for some reason you're not on one of them, let me know and I can go ahead and add you. These are also our, I guess, 2026, right? Our quarterly meetings. I'll add the other 2, but I'm sure everyone can figure out the cadence based on what it has been. Also, I just wanted to share some possible agenda items for our future meetings. I know we had done last time the work group kind of report out and a bit of breakout session. So we'll try and incorporate that back in. It just felt like we had a lot to discuss today that was all very relevant. So that was the only reason we didn't include that in this meeting. But we would like to keep it kind of on a reoccurring basis, just so folks know what's going on in the work groups, get feedback, things like that. And I think one item that's just been kind of on the agenda back burner is just discussing membership at some point, see if we want to do any sort of recruitment to maybe get our membership up. Also, I had on here Senate Bill 3. We discussed it at our last quarterly meeting. I don't know if Jackie's still on, but I don't think she was able to fully report out. And obviously, there's a lot of moving parts there. So certainly wouldn't be bad to have them. Obviously, the funding, which January, we're kind of at the cusp there. But I think keeping that on there as well. What else? Those policy changes that you all have discussed, I certainly think we can continue that. And I didn't have it on here, but obviously it's probably on everyone's mind, is the rural health transformation, the application. Obviously by January, we'll know if we've got the funding or not. And And there's the RFI out right now. We're just finally executing the contract for the consultant that's helping write the application. So been pulled in a little bit about that, but if you guys have any, questions or anything on that, let me know. But we certainly, I think, will put them in touch with you probably sooner rather than later, because we're really trying to gather as much as we can for our application, and it's a pretty short window, but we'll make sure that they also are included as we move forward with that work. But yeah, just wanted to throw out there if people have other thoughts on topics for the upcoming ones. I know Maggie, you had some great ideas. I don't know if you wanted to share with folks. I mean, I think along the same lines of behavioral health, right? Senate Bill 3, continuing the conversations around behavioral health integration. You had some great ideas. So
Where did you see these great ideas?
well, you brought it up in the behavioral health integration work group. One of the ones, I think it was just me and you, and we were just chit-chatting about, possibly having some folks come maybe to talk about really good integration models that are already happening around the state.
Yeah.
That might be an
I'm sorry.
idea.
I'm just blank.
It's okay. Sorry. It's a
No,
long meeting.
what the one thing I do remember that I say a lot is that I think we need to pay attention that behavioral health integration can take several different forms. It's not going to, I don't think it's going to work to be the same model for every provider in the state. I just don't think it'll work because the FQs have one model and then the community-based services have another model. And so I think it'd be helpful for us to focus on how we help organizations build that integration and support that around key themes, not necessarily on key structures. I don't know if that makes any sense.
Makes sense to me.
Thank you.
Yeah. Yeah, so if anyone has any other thoughts or ideas, certainly send them to me. I'll follow up with folks. I guess the only other thing I just want to update folks, we will have a new staff member joining me and LaDawn's team. They'll actually be under LaDawn, but they will be helping with the primary care council and the work group. So yay, help, because I need it. And I know, the work groups are needing that extra help. So it'll be really nice to introduce him to you all. He starts next week. Darn it, he couldn't make it today, but I think you all really like him. He's done a fellowship with one of our deputy secretaries. He was currently working for CDC, and just has that wonderful young public health energy. So I'm excited he'll join us and be able to start helping, I think, with some of these work groups and agendas and inviting presenters, all that stuff. I just really haven't had the capacity to do. So I'll share that information probably at least by email, just so you get to know him, and you'll start seeing him pop up in the work groups. So I think that was it. Does anyone else have any other updates they want to provide the group?
I just wanted to say that, Tristan, I really, really appreciate your land acknowledgement. I know it's way at the beginning, several hours ago, but I just wanted to throw this out to the group. But I don't love land acknowledgements because it's like a wallet stolen acknowledgement. Hey, I stole your wallet, and I acknowledge that I stole your wallet. Okay, so good, right? So I like a land acknowledgement that talks about reparations, and I think that Tristan really said that in her land acknowledgement. It talks about giving back and increasing equity. And quite frankly, I think what we do in our group, what this PCC does, is foundationally that. And so I think the work that HCA does, I think that the work that Medicaid does, I think the work that the people around the table here does is giving back and increasing equity and making a difference. So I just wanted to say that I really appreciated that. And people see why I think that's really important, because don't acknowledge tell me what you're going to do to fix it. And I think what's that what we're doing. That's what we're doing. So thank you. Thank you very much.
Thanks, John. I appreciate your praise over my land. They take a long time to write, honestly, when you think about them really hard. Me and John had a whole conversation at, I think it was the Family Practice Conference in Ruidoso about it. So if anyone wants to read theirs, I'm happy, you know, I just read my same one every time, but I'm happy if someone else wants to read one next time.
Can you send me a copy of yours, Tristan?
Yes, mine's even longer. I'm not allowed to say all of it because there's other stuff in there, but I just keep, I'll send you my full one. So yeah.
I have a copy too. Thank you for doing that.
Yeah, sure. I'll share that with folks. Yeah, anything else anyone wanted to share? Okay,
And-
well, go
And
for it, John.
Man, I don't want to say too much, but I'd also like that if we need to do some foundational primary care education, I think I would be happy to do that as well. Just to say how primary care contributes to communities and society, because there's tons of literature on that. And I don't know that everybody knows that, but I'm a primary care nerd, so I know it. So it'd be nice if we started doing that within the group itself too.
I think it'd be great, Jen, if you have like a summary page or, you know, one pager that we could refer to. I think it's super helpful information.
Okay.
Yeah. Sounds good. Well, I'm glad we're ending a little, like 10 minutes early. It's a long meeting, so
Thank you.
yeah, let me know if you all need anything in the meantime.
Thank you.
Thank you.
Thanks, everyone.
Bye, guys.
Bye.